Perfect. Good afternoon and good evening, all. Quick audio check. We'll get started in about 30 seconds and give everybody a chance to log in, grab a coffee or some wine, or both. As everybody starts to flow in, a nice rainy, cold day as we approach the lovely fall. And Darrell, you already got your extra coffee to keep you the true lifeblood of all physicians.
Oh yeah, caffeine drip.
No kidding. Excellent. Fantastic. Well, without further ado, ladies and gentlemen, we are recording tonight's session. Thank you so much for your time. This is, again, it's been a true privilege. It's been a while since we've done one of these great seminars specifically for physicians, but it's been true and significant changes across the board. So welcome all. We look forward to, certainly having a great course for you. So with some quick introductions, I wanted to introduce to my right, left, or wherever they may sit on your screen. First of all, Dr. Darrell Ginsberg is a true friend of the family, and exactly what you would hope for in a physician. It was a privilege to connect with Darrell back, not when he graduated medical school back in 2014, but in 2020 when came through with an idea. And it was literally that idea with some friends and colleagues at the time to open their first clinic, and men's health clinic at that, and having the first conversations and seeing it now all the way through the first and now the second practice back in 2020 and 2021. Darrell, thank you so much for joining us, and look forward to hearing all about your story.
Yeah, thanks. Appreciate you guys for having me. So I think we'll just jump right in. Just to introduce myself. My name's Darrell. I'm a family doctor and hospitalist. Uh, Graduated 2014 and worked as a hospitalist for about 5 years. And At that time was teaching at McMaster, and then now teach at UFT and McMaster, and also take some students from some other colleges. Maybe we'll switch to the next slide. So the original thought here was before the clinic started was just seeing men come into hospital who were sick, often hadn't been to the doctor in 10, 15 years because they were quote unquote perfectly healthy. Thought to ourselves, how can we get to these guys earlier? We could probably stop a lot of things that I was seeing in hospital, guys coming in their 50s, 60s, 70s, if we can get to them earlier. Just started doing kind of side research, but thinking of building a clinic. As I started researching and looking at some of the statistics about the disparities in mortality and morbidity between men and women for a lot of different diseases. Thought about some of the reasons why men don't go to the doctor, and we found lots of reasons. Long wait times, cultural reasons, um, lack of after-hour services with men often and women, but men mostly not want to take the day off work to go into clinics. So we started thinking that could we build a clinic that's going to focus on men's health, and that's when Unified Men's Health was born. And if we stick to the next slide here, the original idea here was to kind of put all the services that would focus on men's health under one roof. So if we can put all the most utilized services men need in healthcare under one roof and make it efficient and seamless, have men be able to come in and see 2, 3, 4 of their physicians all in one morning, all who are sharing information and administration. What would that look like? So what we looked to focus on was on male-focused care in a multidisciplinary fashion with increased convenience, and offer OHIP services for the most part But as anyone physician here knows, you can't just get a clinic by on OHIP services alone. So, are there any private services that can also supplement the OHIP services as well? And if we go to the next slide here, so we started looking at what would be an integrated model of care where family doctors and specialists and allied health are all working together. How can we make it efficient? How can we make uh, what I would say a mini hospital inside the hospital? People like hospitals, and hospitals work well because colleagues see each other in the hallway, they meet at lunch. People don't often pass down bad referrals, at least in a non-academic center, without having residents or fellows to punt down to. But between colleagues, often is a much more collegial environment, and the often seen outpatient experience of family medicine passing off referrals off to specialists, faxing things into the ether. Specialists don't know family doctors don't know specialists, and they just put everything under one roof. OMA actually had looked at this before and had position papers looking at what they call the integrated ambulatory care model, but nothing actually that's been mortar built on the ground. So we thought, maybe we can do something like this. If we go to the next slide. So it was myself and friends from medical school, a cardiologist and an orthopedic surgeon. Kind of thought, let's get together and build something. Now, for a lot of people who are at this talk, they're going to have an idea for a clinic, maybe an idea of a general location or a specific location. For us, we want it to be kind of mid-central Toronto to east side Toronto. We want it to be close to a lot of the main hospitals. We want it to have lots of parking. We want it to be subway accessible. That's not usually for patients. That's often more for staffing. So we had this general idea of location that we wanted, but really needed to firm this up. And then we had the question, okay, we have the idea for the clinic. We have kind of a general idea for where we want it to be. Like, where do we go next? What do you do at this point? I'm sure a lot of people here have ideas for clinics or have thought about what they want to build, but, kind of where do you start? So if you go to the next slide here. So what I would suggest to anyone here is really reach out and speak to everyone you can. Clinic owners, it's a physio owner, it's a dentist, whoever it is. Go and speak to people and find out, hey, how did you do this clinic? Who helped you here? How did you get into this space? Like, I really like this, the way you did this or that. I like your front desk, whatever it is, just try to get as much information as possible from different people. In my case, my dentist, I just really liked her office. Started asking her, who helped you get this office? This is really nice. Who built it for you? Who did this? Who helped? He pointed me the way of Cirrus. And then kind of once I met Cirrus, things started kind of flowing because they understood all these questions I had, and they were quite helpful with introducing me to contractors with healthcare experience like Acecon, talking to me about, here's the steps you need. Now, for most people building clinics, they need to go to the bank and get funding. And as any physician on the call knows, banks love doctors. Everyone probably has their knapsack from MD Financial from one of your med students as they tried to get us early. But in general, doctors can pay back their loans. Banks are going to be happy to meet with doctors. Scotiabank, TD Bank, RBC Bank, MD Financial, which is Scotiabank now, all have healthcare divisions and are all pretty happy to meet with doctors and help them kind of build out their businesses and build and help them obtain loans. You do need a business plan. You do need accountants. You do need lawyers to help with corporation shareholders agreements. But especially with lawyers, try to limit their use as much as possible. Don't reinvent the wheel. OMA Legal has information for you. You can use paralegals. You can use Cirrus to help point you in the right direction as well. I think it's a big mistake a lot of new businesses make is they spend a lot of money on lawyers, and they're often doing the same work that's been done 100 times before in shareholder agreements or incorporation. They're needed, but I think if you spend the time to research, you can find a lot of the information that they'll charge you for. When it comes to finding space, you can go with your own real estate agent. Cirrus was helpful. They can help you, connect you with a real estate agent as well. And when you go and talk to landlords, doctors are often in a good position because we're good tenants. We often can pay there's no lack of demand for healthcare. We can often pay off our our rent. Once it is uh, built, clinics rarely go under. Um, and depending on where the facility is, a clinic will see a good footprint of people going in and out, and that leads to a lot of parking fees for the facility. That's something also to keep in mind when you're negotiating your and looking for a lease is, are you going to be contributing to the overall parking income for the facility? If you're running a high volume walk-in, that'll be a yes. If you're a psychiatrist seeing one patient an hour, probably not, and that should affect your rent as well. Um, so the where to begin is the part people really get stuck at. Once you have your general idea of what you want to build, I want to build something, talking to Cirrus, talking to uh, colleagues that that have built things, or even allied health professionals or dentists that is really a good place to start. We'll go to the next slide here.
And the updated stats on that, Dr. Ginsberg, is it's less than a 0.5% chance that the doctor defaults after 10 years. And bankruptcy rates, the last stat I saw was 0.026%. Right.
Wow.
So yes, you are AAA gold in the eyes of a landlord and the banks as well.
Yeah, for sure. And banks will and should generally kind of fall over themselves to help. Not to push banks too much, but banks are big organizations. They're not just giving you a loan or a lease. They also want wealth management. They want to help you with your insurance. They're big horizontal organizations, and um, physicians are pretty valued customers. So I would say once you kind of thought of your idea, have your business plan in place, or often even in parallel to that, have an idea of where you want to build. You really want to discuss with uh, healthcare contractors that know what they're talking about. There's a ton of contractors, and everyone has an uncle or a cousin or someone who knows someone who can help and build it. You need people that understand healthcare, and you need people that understand all the requirements that healthcare has, which is way different than opening a clothing shop or a restaurant. All these things are very different codes, different um, requirements, and different ideas of how you want your clinic to flow. So it's definitely worth it to engage a contractor earlier in the discussion. Often, even for your business plan, they're going to want a drawing of what it's going to look like, what's the idea, and talking to contractors and architects early can be really helpful deciding how much space do I need. I think we only need 5 rooms, so is this enough space? Um, uh, Understanding the requirements for bathrooms, universal versus accessible is really important. So talking to those, if I was going to say anything, just to one pearl to get across in this discussion is experience really matters. And speaking to those who understand healthcare, we definitely wasted a lot of time speaking to people that didn't understand healthcare and try to explain the healthcare system, public versus private, and requirements for disabilities and accessibility. It's just a waste of time. You find people that can be knowledgeable and can be teaching you things instead of you teaching them things is well worth it. Next slide. Good. Yeah, and then this is the fit again in terms of like what I meant in terms of you're going to be approached with lots of different people when you start building, and uh, there's a difference between an architect and a interior designer and a contractor, and having people who know healthcare and can think to you, well, you may not want to build an operating room here now, but maybe in the future you do. Piping and ductwork and wire, all that stuff is really cheap, relatively, and easy to do when the walls are down. Once the walls go up, everything becomes more difficult. So understanding kind of what you want to build now and what you want to build in the future is quite helpful as you plan for your space. But again, really speaking to people with that experience is going to be the most important thing that I try to push upon everyone. Just like a doctor, a first-year med student is very different from a person who's been in their career 20 years, and that experience matters. And I think now I'm going to be passing back to back here.
Yeah, perfect. Thanks, Dr. Ginsberg. It's key. And what I wanted to do as well is We're going to have the Q&A open, guys, and certainly the chat. Feel free to ask questions as we go. We're going to have a section for Q&A. We're going to keep things moving pretty quickly. We also want to customize some of the content. So we did a quick little introductory poll. Tell us a little bit more about your situation. Do you lease your space? Do you own a space? Are you looking to open or relocate a clinic? Are you looking to potentially acquire a space? Are you planning to potentially transition, right? Staying put and grow the business. And then also some information we'll touch on with the leverage. And that was the key piece, especially as we went from 1 to 2 locations. Term and options matter. Might matter to the banks, certainly matter to the long-term value of the clinic and that predictability and continuity of revenue, which are key. From that perspective, it's my privilege to introduce the 2 founders of Acecon, going all the way back to January of 2013. Ali and Puyan are incredible experts and really interesting about the shift. So we connected, oh gosh, probably at least a year ago, and then again in person not too long ago. And it was this interesting shift where they went from doing a lot or the majority of dental clinics to now doing the majority of medical clinics. So they've really been on the cutting edge of all of these craziness. And can we take 2 steps back to recognize Dr. Ginsberg and every physician in Ontario and the country and how difficult it is? Right? How hard is it to make money as a physician these days has never been more difficult. My dad's clinic back in 1974 was probably a whole lot easier than it is now. It's all about efficiency. So as Dr. Ginsberg was saying, how much can we get through to see the right patient, to see the efficiency, and how do we even break even, let alone become profitable? So it is incredibly difficult. And the layout of the space, the build out of the space, that patient flow, the efficiency is a huge takeaway from working with Dr. Ginsberg. So that's a great perspective and a great lead in. So I'll pass it to Ali and Puyan to start talking specifically about now themselves, the build out process, the design process, and then we'll get into some of the core business components shortly thereafter. And Puyan, you should be able to control the screen, or you might need to re-click. If not, I can re-add you.
I think I can.
Okay.
Thank you for that introduction, Eric. And thanks for that presentation, Dr. Ginsberg. It's actually a pleasure to be doing a presentation with both of you because we had the opportunity of working on the same project together. As Eric mentioned, we're Acecon General Contracting. We actually often do these presentations regarding healthcare construction. We have done a number of these for basically all the major banks, as well as some of the other healthcare-oriented firms like equipment suppliers, specifically dental suppliers, and a few different institutions. We're generally considered one of the leading experts in the field of healthcare construction. Now, healthcare design and construction happens to be a very complex niche. We won't be able to cover it here in a very significant way, but we're going to do our best in the time that we have. But if anybody has any questions, I would encourage them to either use the Q&A that's available, including at the end. But if you have any specific questions about a very specific concern, about a situation that you might be in an already moving construction project, feel free to just keep my contact. You can always call me, and we'll provide that information as best as we can.
That's great. Dr. Ahmed just posted one. We'll cover that towards the end, but some good questions about, again, building long-term care facilities, which I know you guys have some good experience in, as do we, as well as, again, how do we figure out funding and funding opportunities with the Ministry of Health. So we'll touch on some of those towards the end as well.
Sounds good. First, a little background about us. As Eric mentioned, we started in January 2013. We've completed over 100 projects across Ontario. You can kind of see a map of them on the background here. You will actually find the same map on our website where you can actually click on every dot, and it will tell you where they are, what the project was, what it is that we did there. Now, a little bit about my background. My name is Poyan Narvar. I have over 20 years of construction experience with a total project portfolio of over $1 billion in both smaller and larger projects. I used to do a lot of institutional projects before. I have a bachelor's degree in civil engineering from the University of Toronto, specializing in constructability analysis, estimating, and scheduling. Also, I have a master's degree in construction engineering and management, also from University of Toronto. In that case, specializing in construction contract documents. I've also been trained and certified by CSA in the infection control guidelines for healthcare construction, which is really a requirement if you're going to be in the field of healthcare construction, although I would mention that most contractors unfortunately don't have this certification. Oh, sorry, I'm going a little ahead of myself. Sorry, there we go. Here's a small sample of some of our healthcare projects. A lot of these projects, we actually had the benefit of working on projects that Cirrus had already conducted the lease negotiations. As I mentioned, for the Unified Men's Clinic, we had the privilege of working with both Cirrus and Dr. Ginsberg. And you can find photos of that project along with testimonials, including from Dr. Ginsberg on our website. We generally complete over a dozen healthcare projects in any given year. And the topic of today's presentation, we're looking at Bill 60, some of the opportunities and risks associated with construction pertaining to new developments in the field of healthcare construction. The photos, the background photos you see in all of our in our presentation is actually all of our previous projects. We'd like to show off a little bit. So, healthcare design and construction is subject to a lot of provincial regulation. This is just a small sample of Ontario regulations that affect clinics. All the regulations that I've actually listed here are amended by Bill 60, the Your Health Act, which is actually a very significant piece of legislation. I won't be able to go over every detail of that legislation because it's like thousands of words, but some of the basics are that the bill, for example, expands the scope of its predecessor bills, adding certain procedures like knee replacement surgery to the list of procedures that can be performed out of a hospital. It allows the appointment of more than one director by the Minister of Health. This has the potential of massively expanding the number of licenses that are going to be issued. This is actually critical. It indicates that the province is moving in the general direction of moving healthcare services out of the hospital. That means that a lot of the early adopters in this field of downloading those fields are going to be extremely successful, and they're going to end up dominating this market. And the latecomers are likely to have issues competing as a few firms begin to kind of dominate. The bill indirectly empowers Accreditation Canada as inspectors, but the inspection is performed on a post hoc basis. They're given broad new powers, including using the police for their spot checks to force a clinic to cooperate. The bill even has some scary language about the police being empowered to, quote, use whatever force the police officer considers necessary to execute the order, end quote, from the inspector. The overall significance of Bill 60 is that the government is indicating this is the new direction of healthcare. It's going to be small institutions downloading many of the responsibility of hospitals, especially for non-life-threatening, non-life-saving procedures. And this is likely to gain pace over the next few years, as, according to the banks especially, as costs in healthcare are outpacing the general increase in the provincial budget. Now, you can see under authorities having jurisdiction, I have listed 3 jurisdictions in blue and 3 authorities having jurisdiction in black. The authorities having jurisdiction in that are listed in blue are not unique to healthcare. They're actually represented in every single construction project across Ontario. The ones that are unique are the ones that are listed in black. And if you're going to take away one thing from this presentation, from me at least, I would say that it's this. The traditional authorities in construction, the ones in blue, visit the site during construction. And they visit the site in predefined stages that are defined in the Ontario Building Code. They check everything in accordance with the Ontario Building Code, and they let us know if there was a problem before there was a catastrophe. As Dr. Ginsberg mentioned, running a pipe while the wall is open or running a new electrical line while the wall is open is not that costly. But once the walls are closed, once everything is built, the costs just go up very substantially. Now you have to undo your work in order to add something and then redo your work. Healthcare construction is, in addition to being subject to the building code, subject to an additional listed set of standards. They're primarily noted in a document prepared by the Canadian Standards Authority, which is a federal crown corporation. The document is called CSA Z317, and it comprises of thousands of pages of extremely dense technical material. Parts of it are mandatory, parts of it are voluntary, but the mandatory parts are referenced in the Ontario Building Code or the legislations that I've listed above, or additional legislation. Keep in mind, there's more legislation than just the 10 that I have here. I just couldn't fit them in. Some building inspectors, particularly in jurisdictions with better resources like Toronto, may be familiar with a few of the requirements, but even that's rare. Most building inspectors have little to no knowledge of these standards. The way the system is set up right now, most of the inspections when it comes to the special healthcare requirements either fall under the CPSO, under the out-of-hospital premises clinics, or Accreditation Canada for clinics that are part of the Integrated Community Health Services Act. But even these institutions are relatively new. They're new to this process of inspections. As the demand is expanding, they're hiring new inspectors, and a lot of them are not really up to speed with a lot of the legislative requirements. They will improve over time as the organizations mature. For dentists, they have been traditionally checked by the Dental College or the Ministry of Health, but they have been at this a lot longer. But even they suffer from the same fundamental problem, which is they check the requirement post hoc. They check it after construction is done. That means when you finish your construction, only then they check and let you know you did something wrong. And in order to fix it, it costs a lot of money to go back and undo and redo your work. When this happens, it typically has a catastrophic consequence on the business plan. Right now, the inspections for the ICHSC, the Integrated Community Health Services, and the OHP clinics is fairly lax. But keep in mind that unforeseen circumstances like a news story, they can lead to radical changes. We noticed this personally with the Dental College. In 2016, there was a massive blitz of inspections of dental clinics across the province, enforcing many of the regulations. Many clinics were shut down until they met the requirements. We know this because that was the year we got a lot of calls, not from our own clients, but from a lot of clinics that we weren't familiar with, calling us for renovations so that they could meet the requirements to open back up. This is actually Unified Men's Clinic. There you go.
Good looking clinic.
I know. So when I do this when I do these presentations at the bank, one of the things that they mention, which actually Dr. Ginsberg mentioned as well, as did Eric, which is that for banks, clinics are a very low risk profile. What the banks tell us is that the failure rate of healthcare facilities is actually significantly lower than other businesses. But more importantly, what they told us is that the failure of a healthcare business almost always happens before the clinic is fully operational. The vast majority of cases happen during construction, right after construction, before the inspection, as part of the inspection process, before the clinic is certified. The banks, of course, they want their money back, which is why they invite us to those risk analysis reviews, and why they seek our expertise. But why do healthcare businesses fail before they're operational? Well, they fail either during construction, with costs exceeding what the business plan's financial burden, or because after completion they don't meet the requirements. Here you can see some of the special requirements pertaining to healthcare spaces. As I said, the code is actually thousands and thousands of pages of dense material. So this is just a tiny, tiny example of the requirements. Oftentimes, projects are actually doomed for failure right from the moment the location is selected and the lease is signed, because the landlord-tenant agreement prevents meeting the legislation's requirements right off the bat. Doesn't have enough electrical service, doesn't have the HVAC requirements, doesn't have some of the critical elements. Other times it's because of poor design planning by the design team. It can also be because the contractor is not properly implementing the design requirements, but that risk is lower if you have a good design team, because at least when they're visiting the site, as part of their project management process as architects and engineers, they can correct some of the errors of the contractor. The risk there is contractor default. That is that either contractor abandons the project or is going bankrupt during the project. This is also usually catastrophic for the project, because as anybody who's experienced it, if you have a project and there is only 300,000 left to pay and the contractor defaults at that point, you're unlikely to find somebody for $300,000 to finish the project. You usually end up paying out of pocket a significant amount of money. The selection of the right location and implementation of the correct landlord-tenant agreement and the selection of the right design team is critical for a healthcare project. This is a big problem because this field is kind of new and there aren't a lot of firms in this involved. Traditionally, for hospitals, the location is often not an issue because they're building in a brand new piece of land and they're building the hospital from the ground up. Hospitals are not leasing a plaza unit and building a hospital inside a plaza, right? So that creates a niche, a unique set of requirements that are not really addressed in the market other than firms like Cirrus. Now, hospital designs are typically done by architectural firms that specialize in healthcare, but those firms tend to be fairly huge and expensive. I'm talking about firms like SNC-Lavalin or IBI. They're international institutions. Nobody wants to hire SNC-Lavalin to design a small clinic, and nor would they even accept such a project. To date, unfortunately, I only know of one architectural firm that kind of specializes in healthcare construction for small and medium-sized clinics, which also are familiar with the Z317 requirements in Ontario. When Dr. Ginsberg actually hired us to do his project, he hired us on a design-build basis, meaning we were responsible for hiring the design team. We hired that specialized architectural firm, Senior Partners, because they are the only firm that we knew which do this type of work consistently. And by consistently, I mean doing at least half a dozen healthcare projects every year, which are subject to the legislation. So why did we hire them? We hired them because it screw up in the design stage. There is no hope for the project. When something like that happens, there's honestly no hope. A contractor, even having a good contractor, can't fix the problems that the architect and the design team are responsible for. And the liability that it creates is just not worth it, given that you're saving like 0.2% or 0.3% of the project if you just hire a cheaper architect or a cheap architect. Architects who specialize in a topic also tend to know the engineers who specialize on the same topic. So I always recommend, if you're hiring an architect, have them hire the engineers. Have them hire the entire design team instead of getting yourself involved in that whole process. Given that most healthcare enterprises fail prior to opening the clinic, the single most important business decision an owner will make in regards to a healthcare business is the selection of a healthcare-oriented team. The team should be selected and put to work before the property is selected for the business. Okay, that means that, as Dr. Ginsberg said, there needs to be some upfront costs that the owners should be aware of, right? Any decent contractor will generally visit a space at no cost to review, but there are other costs. Like an architect, you need to do a zoning review to make sure that you don't have zoning issues. You need a lease negotiator to make sure that you have the healthcare requirements associated with this location that's being selected. The three largest of construction risks generally are: one, existing conditions, which also includes the landlord-tenant agreement; two, the design team selection; and three, the contractor selection. And that's, by the way, in order of priority. The team should be set up right away to address all of these risks, sources of risk immediately. There are various steps that you can take to limit contractor default risks. The first thing you should check is if the contractor that you're talking to is even real. I don't know how many times I've been called to clean up a mess because somebody was getting a price, some crazy price for a job from a contractor that didn't even exist. I guess our industry, everybody thinks that it's very easy to be a contractor. So there are a lot of people that are pricing jobs that are not even real contractors. And there's a few ways, by the way, to check if the contractor that you're talking to is real or not. Every contractor that works in the province of Ontario is required legally to have WSIB clearance certificate. It's a very easy thing to ask. It's very easy for us as contractors to provide that documentation. Every contractor has liability insurance because basically every landlord in your landlord-tenant agreement is going to require your contractor to have liability insurance, at least for $5 million liability, oftentimes for $10 million liability. Okay. Pre-qualifying your contractors, meaning selecting contractors that know what they're doing, will prevent hero quotes, which often lead to poor decision making. You know, you get a quote for 1.2 million, another quote for 1.3 million, and you get another guy pricing the job for 500,000 because he doesn't know what he's doing and he's pricing a job. It just leads to second guessing your decision constantly. If a contractor is not qualified to do the job, they shouldn't be invited to price the job. Okay. Clear scope definitions reduce extras. Typically, architects take care of this aspect of the job unless you're doing design build. As healthcare professionals, you guys should not be expected to know the building code or the additional healthcare provisions. The core requirements should be the responsibility of the contractor in a design build setting or the architect in a design build in a traditional setting. And if anybody has any questions about what those mean, what the design build and design build is and which one is right for you, feel free to ask at the end. I won't have time to cover it, unfortunately, in the presentation. When it comes to designers, be aware that design errors are actually unavoidable. You're representing a 3D space in a 2D drawing. This is the subject of decades of research, and every new generation thinks they've solved the problem. When I was coming out of school, BIM, building information modeling, was a huge deal. Now everybody's talking about AI. That problem is never going to get solved, at least not in my lifetime, I don't think. You can always hire an interior designer for the aesthetics of a clinic, but beware, many interior design firms claim they can do healthcare and meet the regulations. More often than not, they can't. I would recommend, if you're hiring an interior designer for the aesthetics, also hire an architect to check the code requirements. And don't make the selection of the architect an entirely cost-based analysis, cost-based decision. An architect that costs you $10,000 less and who doesn't know what they're doing can easily end up costing you $300,000-$400,000 in extras. As we've been discussing, healthcare construction has a lot of unique facets. The structure of your lease is extremely important, not just in terms of construction, but also in terms of the valuation of your healthcare business. That's why there is a niche for reviewing leases for healthcare businesses. They ensure the leases meet the requirements which allow the construction of a healthcare facility as per CPSO and AC requirements. For us, the jobs are always easier when somebody like Cirrus has done the lease review. And we've seen a lot of jobs where we start and somebody else, like let's say a law firm has done the lease review, who they don't usually specialize in understanding healthcare spaces. And when we take over, we realize we can't even build the clinic that the client wants in this space because it doesn't have the requirements. This is actually extremely important. And actually, on this note, I will pass the webinar back to you, Eric, so you can take us through that aspect of the process.
Appreciate it. And full disclosure, Puyan had about 87 slides with 400 legislation acts and specifications and wanted to go through each and every one. But in the essence of time, thank you, Puyan. Great job. It's a key piece. I mean, the core takeaway, looking at it from 10,000 feet is, my God. This is not to be discouraging about opening your first clinic, but more so just to sort of dip your toe in the water about how important the structure is, the team is, and more importantly, don't do this on your own, right? As Dr. Ginsberg shared, there's, things that you do once or twice, right, a year, great, do it yourself. Things that you do once or twice in a lifetime, right, get the right pros so you've got the understanding. And as the privilege to be the owner of Cirrus Consulting Group, Cirrus was founded 30 years ago in 1994 by a group of doctors in Alberta that partner with some real estate experts. And since then, we've been involved with over 13,000 dental and medical office lease negotiations. We are the only healthcare specialized tenant advisory and lease negotiation firm of our kind in North America. Fundamentally, we saw doctors graduating from dental and medical school, driving around their local strip mall, and before they knew it, they were signing these multi-million-dollar contracts on the trunk of a car without truly understanding the importance of it, and more importantly, how much leverage there was. And one of those, oh, well, I thought it was just a standard form lease. So Cirrus, again, really unique from the fact that we've got lawyers on staff. We've got some of our lease negotiators have come from a business background or come from the landlord background. So instead of negotiating against the physician, we've hired them from the landlord side, from the dark side, to now represent the physician through the process. Plus, we have all the real estate analytics and all the big licensed software to help ensure that we're right there from the very beginning of the location search, dealing with the landlord right from the very beginning, right from the letter of intent, inserting Acecon to help make sure that we have the best layout and everything's lined up long in advance before we sign that binding letter of intent. From that being said, we're sort of this neat little sweet spot where, again, typically what happened was, as Puyan was just mentioning, the doctor signs a binding letter of intent without really understanding that they're now locked into this lease. And then the broker refers to the local lawyer, right? And again, without that experience in healthcare, without the ability to, again, not being paid for by the landlord, right? We've always been paid by the doctor. We support them throughout the entire process, right? And that's a little bit about us. The data becomes important. So, we have over 95 billion square feet. So when we were originally connecting with Dr. Ginsberg, we were looking for locations, availabilities, ground floor retail, right? Commercial, throughout key parts, right? Near all of the public transportation, etc., right? And then we can, especially knowing a rough radius, we can really help to dig in. So just as a prime example, these are just some of the very recent lease negotiations we've done for doctors throughout Ontario and the GTHA, but we cover all of North America. And it's a privilege to work with a lot of those key partners across the country, let it be on the medical supply side, right, or others, where I was just with Medline recently, that, again, a key component to help make sure that doctors are set up for success. There are so many different entities that are predicated on the success of the correct operation and opening of a dental clinic and medical clinic. It becomes very important that it's done and set up correctly. So facts matter. Right. Right now, especially as it pertains to rental rates, vacancies, comp reports, right? It is such a fantastic market to be a physician. Landlords and Cirrus, as we've been helping doctors for decades, we've also helped Ontario physicians better bill OHIP for services rendered, was part of our a previous business that we had since spun off. But most importantly, right, landlords love physicians. Pharmacists love them even more, right? And there's lots of fantastic scenarios where there's a great symbiotic relationship across the board and an incredible value for these businesses to be partnered with or work closely with, right? Any of those medical ancillary type of medical businesses. The data matters. So again, demographics, one of the key things we've done as Dr. Ginsberg mentioned for Dr. Whitaker and Dr. Ginsberg and others is let's figure out what do we actually want to focus on. And this is some of the data, that license data we utilize. So it shows, here's the building, here's, who owns it, here's how much it's sold for, here's all the transportation, here's what we know about the landlord. And then to the right, everything in terms of what we want to focus on. Right? What's the men to women population, for example, as Dr. Ginsberg mentioned, right? What's the population sub 19, right? For some pediatric type work, right? What's the aging population? How does that compare to sex? And making sure that there's a long-term alignment. This is one of the key pieces we've done for physicians, dentists, veterinarians, et cetera, is this new practice checklist, right? Where does the doctor fit in throughout the process? Mission statement, building your team, market, space finding, right? Where does the lease negotiator, right, fit in? Where does a broker fit in as needed? Where does the equipment provider, general contractor, landlord, architect, design, et cetera? These are such a difficult space, and it can feel so lost when you're trying to work at the hospital. You're working in a new clinic and you're trying to build this out at the same time. It can be absolutely insurmountable. But helping to make sure you've got the right team that does this all day, every day, it makes things so much easier. And then it's a great conversation to say, okay, great, doctor, do you have the design work done, right? Have you looped that in? Have you sent the design layout to the landlord in time? Have they signed off on it? Can we core? Can we drill? Have we got Acecon in there to be able to make sure that we can successfully execute on your vision? You're the boss. You choose who you have and when you have, right? But certainly minimizing those surprises and oops, right? Yes, it's an upfront cost. Yes, it can seem like it is a big investment, especially coming off your personal, credit cards, with your first business expense. But it's a key part, making sure that again, the lease and the construction becomes literally the rock solid concrete foundation to build your future business upon, or it can be a crumbling shell that can cost tens, if not hundreds of thousands of dollars to fix. So from a startup guide at a very high level, start with that plan. One of the things we do for our clients is we will calculate the pro forma. What's the total run rate, the burn rate, if you will, year 1, year 2, year 3. There are so many different variables that you can negotiate within your lease. Base rents, annual increases, common area maintenance, fixturing, free rent, tenant improvement allowance, landlord work. There's so many, there's tens, if not hundreds of thousands of dollars over the term of the practice, right? But in life, you don't get what you deserve, you get what you negotiate for. So therefore, we've had the privilege of helping to take all of that stress of dealing with the landlord off of the doctor's shoulders and helping to make sure that we get to a proper agreement, right, to minimize the surprises, and right from that landlord work section, make sure we include a lot of those requirements, obviously, that Puyan mentioned previously. Right, so what should it do for you? If we waved our magic wand, number one is, yes, it should be fair and affordable financial terms. We talked about efficiency. We talked about how little physicians are being paid for by the government per patient. It is atrocious. As my father reminds me every day, looking at all the other occupations out there and all the big raises and pilots and whatnot, right? Yet the physicians are still getting the same amount as it was from decades ago. So knowing that, the value of every penny, we have to make it stretch, right? Also, making sure we have a long-term lease, term, options, and predictability. And how do we minimize risks of things like demolition clauses and relocation clauses are key, right? And, the risk and exposure. My godfather, tore his rotator cuff as a GP dentist at, midway through his career, and unfortunately needed to sell his clinic. And very, very quickly. So as a result, one of the key things we always want to have is a medical specific death and disability clause. One big takeaway from today is making sure that your lease has medical specific language. right? Meaning, right, a lease that is designed not for the nail salon next door, right, but for your high visibility, right, high patient flow clinic. So things, if you could become disabled, if you're unable to practice, right, if there's some sort of a challenge, you should have the ability to terminate the lease, or heaven forbid you pass away. If you are a personal guarantor, your estate then becomes bound to the lease. These are all the things they never teach in medical school, but certainly now that you're entering into a commercial lease, it is not like residential, right? It is between two corporate entities, and you're up against some big one-sided teeter-totters of the landlord, right? And our whole goal is to keep that there. How do we make it flexible? How do we have the right term, the options, the ability to transfer out? What happens if you need to move out of province? What happens if you want to bring in partners? Most physicians don't realize that if they bring in some different partners and they change the shareholder structure more than 25%, they cannot do that without alerting and getting the prior written consent of the landlord through the assignment and subletting provision. I'll say that again, just for bringing in some additional partners, which happens all the time. But if there's any sort of change of control, in some cases of as little as 25%, you can be in default if you have not received the prior written consent of the landlord. They want to know who's in their space. They want that control, right? And of course, right, what's our exit strategy? How do we want to help to make sure that we've built the success? What does that transition look like, right? Let it be selling or transferring or otherwise. On the intake, it is so much easier to negotiate a great lease than it is just before you're about to retire. So, there are so many different sections here, as I mentioned before, but don't underestimate how much potential value there is. Can we get a $2, $4, $5 per square foot reduction in rent? That could be $50,000 or $100,000 over the term. The annual increase, if we lock in the first 5 years, the banks love it, right? MD or otherwise, to help make sure that we've minimized that additional upfront cost. Common area maintenance fees, right? For Darrell's clinic or otherwise, easily 50% of the base rent can be towards triple net, taxes, maintenance, and insurance. That is negotiable. It could be capped, it could be limited, it could exclude other brokerage or legal fees. These are all the little hidden fees that many doctors building at their first clinic just don't even realize. Gosh, God, Darrell, I thought it was $30 a square foot. Why am I paying $45 per square foot? And the landlord says they can charge me any of their additional fees directly to me. So, and then tenant improvement allowance. Be careful with this. Landlords are not in the lending business. So the more things we do in advance to help leverage our leverage and make sure that we're getting sort of levers on the wall. One quick math example as we wrap up here in a second is $5,000 a month, increasing at 3% per year, represents over $2.9 million over the next 30 years. That is what the landlord sees. The landlord sees a dollar sign on your forehead. They don't see the stethoscope around your shoulders. They see a dollar sign. That's it. They don't care about your patients. They don't care about the community. They don't care. The biggest focus is term and rent, right? I'm painting a wide brush, right? I'm using generalities. I'm sharing my opinions, but ultimately, right, in the full perspective is, right, it is a for-profit business, and their goal is to bring in great quality, high-quality foot traffic, fill their spaces, and collect the rent. Now, for those of you that own, you're not off the hook, right? To own your space, it is just as important to have a lease separating your real estate corporation from your practice corporation. Loans approved, tax and audits, liability slips and falls. And if eventually you want to keep that building as a passive form of income post-retirement, that lease becomes critically important. And heaven forbid, something happens on the drive home from the clinic and you pass away, if you need to transfer that lease and you want to keep the real estate, the ability to have a clean lease separating those two entities are critical. I'll skip these in the essence of time. There'll be a little section for some of this data afterwards, but knowing your lease expiry dates, are you personally guaranteed? Option to renew deadlines are key. If you own your real estate, right? Is it yourself? Is it your corporation? Is it you? Is it your spouse? Are you paying yourself rent? Are you overpaying or underpaying, right? Is that going to be a CRA issue based on not aligning to market price, right? And help to rate the state of your estate. Lastly, one practical example is, and good news, as much as Puyan was going to go through every single legislative change, we are going to go through each and every one of these and just some of the clauses we go through in each and every lease negotiation. I'm kidding. But it's a great screenshot. These are just some of the few dozen clauses we focus on and need to make sure that it is medical specific, right, in your lease agreements. A big one that is a bit of an epidemic throughout here in Toronto, Ottawa, Winnipeg, Halifax, right? Any basic major city is the demolition clause. This is not going away. Brand new, new buildings. Concord just had me in speaking. Some of these, brand new RioCan, et cetera, buildings will have demolition clauses in them right from day one. Brand new building. Their glass isn't even in yet, but you'll have a demolition clause. That's okay. Banks are becoming more familiar with them, but they're also quite negotiable. So let's look at some of the red flags. First of all, be careful with this, because even if the landlord intends to demolish or materially alter the project, your 10-year lease is done and you are out. So that, right, is not sufficient, and nor would you ever want to make a significant investment and have such a one-sided clause. Also, what is the notice period? Most landlords give usually between 3, 6, maybe a year worth of notice before that termination right is given. You've got to be careful, because look, if you're in a medical dental building and they give every single physician or specialist, right, a brown envelope on the door, and everyone's got notice to get out, you want to be the first one to find that premium location, because if not, you're going to be scrambling and paying above market rent and beyond. Landlord can terminate without any compensation of any kind whatsoever, right? And lastly, right, again, there is 0 payments and maybe, if negotiated, some specific benefits to make sure it's a smoother exit. But that demolition and relocation clauses are 2 specific pieces that are negotiable, that could easily be upwards of $250, $350 per square foot, and can cost hundreds of thousands of dollars of liability and risk. How do we buck this trend? Well, number one is, do not fall into the landlord trap. This is the courses and seminars that landlords go to help learn how to negotiate against doctors. And what they do here is, think of this as a clock. This is the way that landlords are taught how to increase their profit without a penny of additional expense. Why? Because as Darrell comes up to his very first lease renewal, right, they will defer, delay as long as humanly possible, knowing that every minute that passes decreases the doctor's leverage in negotiating the renewal of the lease agreement. And yes, every 5 years or 10 years is the best time to treat it as if it's a whole new lease, negotiating a net new 10-year term and 2 5-year options, right? The last thing you want to do typically is just exercise an option, because you use that up and then you're left with nothing when you might need it, or heaven forbid, you needed to retire, transition, etc. So this is a key one. Start the process 24 months in advance. Gives you that much more leverage, especially with some of those larger landlords. So the solution here, ultimately, over 30 years of helping doctors negotiate and renegotiate their dental office leases and medical office leases, is number one, get all the facts. Get the original lease that the original doctor signed in 1986, and every amendment, every rider, every exhibit, every transfer throughout. That's the governing document. And then, right, as Dr. Ginsberg and I did way back when, let's talk about goals. Let's talk about transition. Let's talk about how we want to build the new business and what that vision is. Then let's talk about the lease. Red flags, right? What are the landlords going to be looking for in the letter of intent, right? And throughout the process. And then what are the facts? What do the demographics look like? What is fair market rent? What do the availabilities look like in North York or in the West End of Ottawa? right? And then how do we come up with that carefully choreographed strategy? But what have we not done yet? Which is what I don't want you to do. For the 47% that have a lease that's coming due in the next 2 years, I don't want you to walk into the clinic tomorrow, pick up the phone and say, Mr. Landlord, I just watched a great course. And now it's time to, right? How much you want to charge me for my lease renewal? We have yet to pick up the phone. So don't skip the first 5 steps of the process, right? As Puyan mentioned, make sure you've got an alignment and a plan for each. And as Darrell mentioned, helping to make sure you've got the vision and plan and execution. Then negotiate the financials, then negotiate the business terms. And don't stop, please, until you get a final form lease that is signed by the landlord. If you never received a signed back version, the version you have is not worth the paper it's written on. On that note, we certainly appreciate everyone's time. It's been a privilege supporting physicians now for over 3 decades. What becomes important now is how do we plan for the future, right? One of the core components here is to know what you need to know and help to make sure you have a plan. So one of the things that we do is an appreciation of your time is we waive our fee for the lease review, demographic, and rental rate analysis. I know roughly about 47% requested a follow-up, either consultation or otherwise. If you're contemplating buying, building, expanding, renovating, critically important you know what the terms are within your lease agreement, right? Also very important that you've got a good understanding with what fair market rent is, right? And then also what are some of the pitfalls and what is that lease negotiation strategy, right? Treatment plan, if you will, help to make sure that we've got a smooth solution. And ultimately, right, you've got the right team supporting you from start to finish. On that note, bang on 8 o'clock. We appreciate everyone's time. We'll go to some of the Q&A. Dr. Ginsberg, other things to add or other key pieces to share now that we've brought up some old memories for you?
No, I think it was a great talk. Got me thinking about our lease coming up and just different aspects of it, and as we look to expand in new locations, as we continue to build. It gives some good food for thought for certain aspects of the lease, and the way like William was saying, the government is pushing more into the community, kind of where it should be. We all learned in COVID that you can't have everything sitting in the hospital. When the hospital shuts down, all healthcare shuts down. So I think they're getting smart now and replicating how it is in other provinces and in the U.S., where most healthcare takes place out of the hospital, whereas in Ontario specifically, at least is all I know, most healthcare takes place in the hospital. Pushing it out and being on the ground floor, and it's exciting.
It's an interesting shift for sure, especially as the healthcare system is starting to implode, collapse, or something in between. It's definitely under more stress than it's ever seen before. So definitely creative solutions and entrepreneurial solutions are key. One question about funding that came from Dr. M was, again, I want to, right, build my practice in terms of funding opportunities and your funding experience. There's always lots of perceptions that, hey, the government's got all these different programs they want to spend, they'll give you money, right? There's all sorts of components, Ministry of Health, the banks, etc. Right? Maybe can you help dispel a little bit of that, Dr. Ginsberg?
Yeah, sorry. I think it's a good question. It's a good question. Generally, governments work in 4-year periods, so any large investment, is not really on so much on their radar, and it's definitely not, at least from what I've seen, it's not the idea that gets through, it's who you know. So, knowing the right people in government, working on a project in a community that's looking for it, it's more going to be local, I would imagine, than it will be kind of provincial. Going to the Ministry of Health and asking, I think the question was from the Ministry of Health. I don't see that, at least on the clinic side. But maybe more so, like if you're looking to build a long-term care home in a small community, or if you're looking to build a clinic in a long-term care home, partnering with a long-term care home, I always think is a great idea. Long-term care homes, especially retirement homes, would love to have a clinic in their main floor. There's a big selling point for them. You know, bring your grandma here to us, to the doctor's office right downstairs. And so that's a good place to look if someone's looking to build, you know, a family medicine clinic or geriatric clinic or medical clinic right in the ground floor of a retirement home or seniors residence is often what I think of as a good idea. Nursing homes, long-term care homes are ministry funded. I don't know much about that world. Probably Puyan would be able to speak more to that world, but I think it's going to be more really looking locally. You know, I've read stories about Peterborough, Kingston, smaller towns really funding clinics for doctors to move into and paying it out of the municipal budget. At least I haven't seen it been paid out of the provincial.
Got it. Second question, I think it's directed toward us, but Puyan, I can pass it through you as well. Is, you know, how do our payments work? How do we get benefited? So, in terms of a lot of the partners you work with, follow the money is a great perspective, right? The banks obviously are getting paid based on the interest and, you know, getting you to sign that loan. The contractors obviously are being paid by the job that they're quoting, right? And to build out that space, right? And hopefully have some money left over at the end. Our side, different from the brokers, is we're always paid directly by the doctor. So as Dr. Ginsberg did, we get hired on a flat rate. Didn't matter how long it took, how many different lease negotiations as it took. We were with them right from the very beginning through then, you know, the grand opening and signing off on that lease agreement. So that's a key piece and a key differentiator. You know, a lot will charge, as Dr. Ginsberg joked, you know, be careful, right? Some of those law firms, etc., will rack up hourly fees, and suddenly it's 30 grand worth of legals, and you're looking, saying, well, hey, what did I really end up with? So yes, the more things you can do, especially finding a partner that's done it so many times, they know what it is, and it's, you know, it gives you the peace of mind of knowing exactly what the value is going through is key. And then lastly, yes, we touched on a little bit about long care homes and facilities, but Puyan, do you want to share a little bit about, again, doctors and building out in a long care home type of facility?
Sure. With regards to the three questions, I mean, we're general contractors, so I think it's a little bit obvious to everybody how we get paid, where our funding comes from. We get paid directly from the doctor, who's often getting a loan from a financial institution. With regards to funding, especially funding through the Ministry of Health or those kinds of institutions, as contractors, we don't usually get involved in that. We're a little bit more downstream from when that process is taking shape, with the whole funding model is taking shape as part of the business plan. What I would say is I do know that architects do have more experience with that in that particular field in terms of what you need to submit in order to get funding. One of the things that Darrell mentioned was, for example, what's the difference between a planner and an architect? So a lot of architects will actually do a planner's job. I should just mention, a planner is involved in the earlier stage of construction than an architect. So earlier construction, part of the design phase. So a planner is involved in what's called site plan approval, which is a process you go through with the city when you're trying to drastically change the nature of a building, not necessarily building inside of it, but changing the nature of a building. Whereas an architect usually is involved in the building permit process, which comes after site plan approval. But they're often, because there is a great deal of overlap between when they do their work and when the funding is being worked out, they often have a lot more information on that topic. What I would recommend is contact us. We can put you in touch with a healthcare architect that might be able to look into that process for, like, to see if it's anything that there is any hope in terms of securing some funding from the ministry. You can contact my partner. He's actually part of the panel, Ali. His email is ali@acecon, that's acecon.ca, and we'll get in touch with you and put you through with the architect. With regards to, do we help in the construction of long-term healthcare centers? We actually get involved in the construction of anything that has drawings. As long as you can give me construction set of drawings and meet the code, I can build it. It's really that simple. So if again, if you have the right team, if you have everything set up for that kind of process, we would love to get involved early on to provide our feedback. But if you can, as I said, if you can get a construction set of drawings or a tender set of drawings for us, anything that you put in those drawings, we can build. And the more complex, from our point of view, generally, the better. I hope that answers all the questions.
Yep, fantastic. And I think there was just a link shared, which I can share.
Sorry,
with
I
everyone.
just threw that in because it's asking about ministry. The ministry did put in some
Yeah,
funding and some budgeting. It started with 30 million. They've increased it to 90 for interprofessional health teams being built. So I don't know the person asking, the physician asking, you know, there is some funding, but what they're looking for in speaking to the minister is they want to know what a number of patients you're going to link to a family doctor. I don't know what you're looking to build, but they want hard numbers of we're going to take 10,000 patients and we'll get them a family doctor. Is really what they want to see on that funding request. Um, so you know there can be some funding. It's you know it's hard to go through and get for sure, but I guess it is possible.
excellent. Perfect. On that note, if there wasn't any extra questions, we appreciate everyone's extra time tonight. Again, the big takeaway from everyone here is you're not alone in all of this. And there are great success stories, taking vision to reality. Dr. Ginsberg, can't thank you enough for sharing your story, the ins and outs, the trials, tribulations, and everything in between. Puyan and Ali, thank you again for your sponsorship and support. We're thinking of doing a lot more of these, again, on the business side of medicine. If you're interested, certainly please let us know. We'll register you for future events. Also contemplating some in person. We've done a number of those in the past, and it's great to come in and get a chance to see in different sort of workstations and different sort of circles of influence. Great opportunity to meet some of the key people in your market that specifically are doing these type of medical deals. It is definitely not easy to be a physician today, and arguably a whole lot more difficult than it was 5, if not 20 years ago. So what we can do now is help to combat that with the right team and the right support. And again, thank you all tonight for your time. And Dr. Ginsberg and the great team at Acecon, we appreciate all your support. And thank you very much, everybody. Have a fantastic evening.
Thank you.
Thank you so much.
Thanks, guys.